This is the chapter 17, the blood chapter lecture. This will be the first chapter of your cardiovascular system. In this chapter, we're just going to deal with the blood, the components, the function of it, and the imbalances that are pertain to the blood itself. And we're also going to look into the blood transfusion. We're going to look into the different types of blood typing, those things towards the end of the chapter. It's a relatively small chapter. Um, and so let's start this chapter lecture by talking about what is blood. Blood basically is an organ because it has different type of, it's actually a tissue, um, connective tissue, which we talked about in chapter 26. It starts from mesenchymal cells, which is why it's considered as connective tissue. It has the matrix, which is a plasma, and the cells that are dispersed in it. So blood acts like a transportation vehicle, so it takes stuff everywhere from different organs to different organs. And whatever you want to deliver to a certain organ, it's delivered through blood. The function of the blood itself, if you look at it, you have three main functions of blood, which is transportation, regulation, and protection. Transportation, like I said, if you want to take something from one organ to the other organ, it's through blood. For example, from your intestine, you're taking the nutrients to everywhere else, or from your endocrine system, the hormones to everywhere else, from your lungs, the oxygen to everywhere else in your body. So that's basically your transportation a function of your blood. Um, Metabolic wastes also are carried to different organs, like, for example, the nitrogenous waste after digestion of protein is taken to the kidneys so it can eliminate it. Those kind of things. Those are the main things for your transportation function of your blood. The next one is your regulation. So, what does it regulate in your body? Helps to maintain body temperature, blood pH, volume in your circulatory system. So, body temperature is basically by vasodilation and constriction, which happens towards the skin. So, in the skin area, you have 5% of blood stored at any given point. So, when these capillaries that are underneath the skin dilate, the blood circulation increases, the heat dissipates from the body. When it is cold outside, the vasoconstriction happens. The blood is diverted to the internal organ. The heat is preserved inside the body. pH, because blood carries bicarbonate buffer system, it is very important for blood pH. If you look at, which we'll be talking about later, the blood pH is almost towards neutral, so it's about 7.4 pH level, almost towards the neutral, which is 7. It has to be maintained in that, irrespective of what you eat or what kind of acid is stored in the body. Like, for example, if you're going on non-carbohydrate diet, you're going to have ketoacidosis, or uncontrolled diabetics, you're going to have ketoacidosis. So it has to be balanced out, and that's by your blood. The next thing is the volume. So based on the blood volume, if you are dehydrated, the blood basically is conserved, the water is conserved through the kidneys, and it increases the blood volume, those kind of things. So that's basically how the regulation function works in the blood. The last one is a protection function. It is what is in the blood actually protects our body. So you have your clotting, and you have your WBCs, and you have complement proteins. Those are the important things that help in our protection. Antibodies as well, which is produced by WBC, one of them. So plasma blood loss is through the platelets that are in the blood. So you are protecting yourself from blood loss, and then protecting yourself from the infection again is through the antibodies produced by the B cells, and then the complement proteins, which are just freely floating in the blood, and then different types of white blood cells depending on which kind of infection you have in your body. Those were the functions of your blood. Now let's look at the composition of the blood. So composition of the blood basically is what is it made of? So if you look at the composition, as I said earlier, blood is considered as a connective tissue, and it's the only fluid tissue in the body, like it's mentioned over here. So connective tissue has to have certain criteria to be considered as connective tissue. It has to have a matrix, it has to have cells floating in it, and it has to have fibers in it. So the matrix is the plasma in the blood. The cells are your RBC, WBC floating in the plasma. And then the fiber is the soluble fiber that is found in the blood. It is your fibrinogen that is floating in there. So and then of course, blood starts from the mesenchymal cells of the embryonic tissue. Because it satisfies all these criteria, blood is considered as connective tissue. So what is blood made of? Plasma, formed elements are the main thing. Okay, so plasma, again, it's kind of like a gel-like substance in which you have your formed elements. We don't call it cells per se because except for WBCs, RBCs and platelets do not have organelles, so we don't consider them as cells. And WBCs, even though they have the nucleus, they do not reproduce in the blood. The only reproduction that takes place is in your stem cells. So you have these formed elements, which is erythrocytes, leukocytes, and platelets. Um, the blood, when you take a test tube of blood and you spin it down, it can easily separate into different layers. The heaviest layer, which is the erythrocyte, settles down in the bottom, which forms the hematocrit, which is the percentage of blood volume that is RBC. For males, because of testosterone, it's higher than females, so it's 47 plus or minus 5%, and females is 42 plus or minus 5%. And then on top of the RBC, that erythrocytes that settles down, you have a fluffy white layer called as buffy coat, which consists of WBCs and platelets. And on the top of that is where you have all your plasma, which is 55%. So this is basically how you're going to see it. So plasma all the way top, a buffy coat over here, and then the erythrocytes settle down, which is the hematocrit value. Hematocrit, again, depending on male or female, you'll have 47 for male, 42 for female, plus or minus. You have to spin it down so it settles based on its weight. Um, when you look at the characteristics of blood, how does the blood look? It's opaque because of all the formed elements that are there. Metallic taste because of the iron and the RBC. It's sticky because of the fibrinogen that starts to form clot. Color depends on which blood you're talking about. If you're taking blood from your venous blood, then it's going to be dark red. If it is arterial blood, it's going to be like very scarlet red blood. pH, like I mentioned earlier, it kind of lingers towards the neutral, so it is 7.35 to 7.45. Your body basically tries to keep that pH level closer to this range, but if it cannot, and if it goes below 7.35, that's when you have ketoacidosis, usually seen in uncontrolled diabetics or people who are in non-carbohydrate diet. Blood itself makes 8% of the body weight. The volume of it depends again. Because of testosterone, males have 5 to 6 liters and females have 4 to 5 liters. We're going to start looking into the different components of the blood, starting with blood plasma. Blood plasma, it's yellowish straw colored sticky fluid. It's 90% water, and pretty much everything that the blood carries is through plasma. So 100 dissolved solutes, nutrients, gases, hormone, waste, proteins, and organic ions, everything, whatever blood transports is through blood plasma. And if you look at the blood plasma, they have main proteins that are there. So the proteins are mostly produced by liver. And the bulk of the proteins that is seen in the plasma is albumin, 60% of it. Albumin is very, very important. It acts like the plasma osmotic pressure. So it dictates which direction the fluid should flow from the capillaries, from the tissue to the blood, or from the blood to the tissue. We're going to look at it in chapter 19, I think so. So albumin is very important for plasma osmotic pressure. And apart from that, it acts as blood buffer, and then it acts as a carrier for other substances as well. The other type of plasma proteins that you have other than albumin are globulin and fibrinogen. Globulin, there are different types, alpha, beta, and gamma. It's all 36% of plasma proteins are globulins. You have immunoglobulins, the gamma globulins, that's your antibodies. Alpha and beta, again, it's for transportation, binds with lipids, binds with metals, fat-soluble vitamins, those kind of things. Um, and then fibrinogen is the soluble fiber that I was talking about earlier. So your clotting, usually that fibers that forms the clot are not in its active form normally in your blood. It only gets activated when there's a damage happening in the blood vessels, or when there is exposure of tissue to the blood. So other than that, if does not happen, then the fibers in the blood that forms the clot are in fibrinogen formation, which is an inactive form of it. It's very important for formation of fibrin, which is active form. Um, then that's all for plasma. There's not much to it. Let's move on to the formed elements, starting with your RBCs. Then we'll move on to WBCs and platelets. Um, so if you look at the blood over here, you'll notice that most of it is RBCs. Those are these pink round ones. And then you have some WBCs. There are larger cells with nuclei that are lobed nuclei, and some platelets, which are dots that you see behind in the matrix. So that's basically, here's another slide of the blood. You have one single RBC or WBC over here, and everything else are RBC, and then platelets in the background as dots. So what is erythrocytes? Erythrocytes' main function is to carry oxygen and a little bit of carbon dioxide sometimes. So erythrocyte is a formed element, meaning it is not a cell. It is a small 7.5 micrometer cell. It transports mainly gas, mainly oxygen, and a little bit of carbon dioxide. The shape of the cell, to maximize the amount of oxygen it can carry, it's biconcave disc shape, and it's anucleated. It does not have organelles like Golgi apparatus or ER or ribosomes or mitochondria. Those kind of things are not there because it needs to increase the space to hold the structure called as hemoglobin for gas transportation. Plus, it should not use the oxygen that it is carrying to different organs on itself. So this is kind of like a function, anatomy and physiology complementing each other. So the anatomy of the erythrocytes is such that it does not use the oxygen that it's carrying on itself. Instead, it actually carries 100% of oxygen from lungs all the way to the tissue without losing anything on itself. So that is very unique in your erythrocytes. The shape of erythrocytes is very important. It has to be biconcave disc shape, um, and it is held with the help of proteins called as spectrin. And the spectrin is mainly because it gives flexibility to the RBC when it's squeezing through tiny capillaries. Like I said, the biconcave is important because it offers a huge surface area, so you have volume of gas exchange enough for it. The entire, or 97% of RBC, if you look at inside of it, it's filled with hemoglobin, not counting the water, of course. RBC do not have mitochondria, so there's no aerobic respiration going on. So they mainly ATP production is through anaerobic respiration. This makes sure that the RBCs do not consume oxygen when they're carrying it. So the thickness on the thicker part of the biconcave disc is 2.5 micrometer and the diameter is 7.5 micrometer. It is very important to have the same diameter, because if it is larger, when it's squeezed through tiny capillaries, it's going to shatter. If the shape changes, then it's again going to shatter. It loses the flexibility. So it is very important to keep this structure in an RBC for an efficient transportation of the gases. Um, because RBC has 97% filled with hemoglobin, we're going to look into more in detail about hemoglobin now. Hemoglobin actually has a protein component, that is the globin portion, and the heme, which is the pigment, which is where the iron is, and gives the redness to the RBC and hence to the blood. The globin portion, if you look at it, it has four polypeptide chain, which is two alpha and two beta chains. And in these two chains, you have one heme pigment bound to it. And each of this heme pigment has an iron atom bound to it. And in each of the iron atom, you have one oxygen molecule bound to it. So if you look at this picture, you'll notice that the darker ones are your beta globulin chains and the lighter ones are the alpha globulin. And in it, you have a heme group. And in the heme group, you have the iron. And in the iron, this is basically where the oxygen binds over here. And technically, one hemoglobin molecule carries four oxygen molecules. So you have about 250 million hemoglobin per RBC, which means one RBC. So 250 times 4, because you have 4 iron. So that means 4 molecules times 250,000, which means 1 billion. So one RBC carries 1 billion oxygen molecule. That's how efficient your RBC is in carrying oxygen molecule. So this is what I was talking about. Now, the important part of your hemoglobin is not only to capture the oxygen from the lungs, but also it has to dissociate that oxygen when it reaches the tissues, so it can give that oxygen to the tissues that needs the oxygen. So when you look at the structure of hemoglobin, there are different types of hemoglobin based on what it is carrying or what it is not carrying. So if it is carrying oxygen, it's called as oxyhemoglobin. It is the scarlet red one that's seen in arterial blood mostly. There are exceptions. And if it is unloading in the tissues, then it becomes deoxyhemoglobin. So it's giving away the oxygen to the tissues that needs it. That'll be in your venous blood. It's called as deoxyhemoglobin. It is the dark red one. And if it carries carbon dioxide. Now, carbon dioxide does not bind to the iron like oxygen does, but instead carbon dioxide binds to the globin portion of your hemoglobin. So when it binds 20% of carbon dioxide, when it binds to the globin portion of the hemoglobin is called as carbaminohemoglobin. So different types of hemoglobin based on what it is carrying or what it is not carrying. So you might want to know the definition of that. Let's look at the production of erythrocytes. How is the erythrocytes made? The formation of all blood cells are called as hematopoiesis, and formation of erythrocytes are called as erythropoiesis. Now, all formed elements are formed in your red bone marrow. In adults, the red bone marrow are found in flat bones and in your spongy bones. Those are the areas where you're going to see your red bone marrow in adults. Um, so now, where is it going to be seen? Axis, skeletal system, girdles, proximal epiphysis of your long bones, like your humerus and your femur. The red bone marrow has stem cells called as hematopoietic stem cells, which has the capability of um, basically becoming into any form cell. So it has the capability of becoming either RBCs, WBCs, or platelets based on what is needed in the body and based on its hormonal um, control that happens in the body. Once these hematopoietic cells becomes committed cells, that means once they commit to become RBC, then they cannot change their mind and become WBC. That's why they're called as committed cells. We're going to see that soon. Let's start with the erythropoiesis first. Now, when you look at erythropoiesis, you have to start with a cell that has all the organelles to a formed element that has no organelles and 97% of hemoglobin filled in it. Now, the process that happens is basically what erythropoiesis is about. So, from the hematopoietic stem cells, it becomes proerythroblasts, which is the committed cells. At this point, they cannot change their mind. The stem cell, the committed cell, cannot become anything other than erythrocytes. So that's why it's called as proerythroblasts. Now, what do you need to do to get to this level without any organelles and 97% of hemoglobin? First off, you have to kick off all the organelles. And before you kick off the organelles, you have to fill the cell with 97% of hemoglobin. Hemoglobin is basically globin plus heme, which is iron and the pigment. So globin is a protein which has to be made by rough ER and Golgi apparatus and all that stuff. So that's basically what is happening. First, the cell fills up with its 97% of hemoglobin. Once it gets to that stage, then it kicks out the organelle. So let's look at what happens from proerythroblast. So it becomes the ribosomal synthesis. So this ribosome synthesis, what is it doing? It's making the globin portion. So the cells initially go to basophilic erythrocyte based on how it stains. It stains blue, hence basophilic erythrocyte. Then it goes into polychromatic erythroblasts. Polychromatic means it has two shades, polychrome, two shades. It's slightly bluish and pinkish. So that's what you're seeing. Why is it pinkish? Because the hemoglobin is starting to accumulate in the cytoplasm. So you're going to see that pinkish hue and as well as a bluish hue stills, hence polychromatic. Then you have your orthochromatic, which means you have completed the 97% of erythrocyte or hemoglobin filling up the cytoplasm. So that is hemoglobin accumulation happening. At the end of orthochromatic erythroblast, you'll notice that the nucleus is kicked out. Nucleus and other organelles are kicked out. Why nucleus? Because nucleus is the one that forms the RNA, and from RNA you form the globin portion of the hemoglobin. So now you have accumulated enough hemoglobin, you don't need the nucleus again. Again, why you don't need the nucleus? Because if nucleus is there, that means metabolism has to take place. That means mitochondria is needed, which means it's going to consume oxygen. So you want to kick out the nucleus so you never use the oxygen that the erythrocyte is going to carry eventually. So at the end of orthochromatic erythroblast, you're kicking out the nucleus and other organelles. And then finally, you have the reticulocyte, which is remnants of the rough ER that are found in there. Reticulocytes usually are not seen in the circulatory blood. You only see about 1% of it. If you see more of reticulocyte, that means your stem cells are forced to produce more and more erythrocytes. So since it's speeding up the production, it kicks out more reticulocytes in the circulatory blood. That's when you see it. So there's something wrong with the blood. Either the erythrocytes are getting shattered fast in the circulatory system, or there's not enough oxygen. That's why you have producing these more in this bone marrow. And finally, and the erythrocyte is formed from the reticulocyte. So these are the different phases that you see in your erythropoiesis. In your blood, there is a table that you have, um, which tells you how many cells, different formed elements are found in your body. So you might want to take a look at that table. So here's the table that I was talking about. So if you look at it, your erythrocytes, you have 4 to 6 million of cells per microliter, and it takes about 120 days a lifespan of erythrocytes is 120 days. After that, it gets shattered, and we'll look into what is happening over there as well. Okay, so once the erythrocyte is formed, it is kicked out into the circulatory system, and then you basically do its function of transportation, regulation, and protection. Let's look at the balance that happens in RBC production. There are two things that control the RBC production. One is the hormonal control, and the other one is dietary requirements. The hormone, the main one of the hormone is EPO, or erythropoietin, produced by your kidneys. We talked about this in chapter 16, that the kidneys produces erythropoietin along with renin. So here's the erythropoietin that we're talking about. Whenever you have hypoxic condition, when you have low or erythrocytes in the circulatory blood, mainly hypoxic condition, the kidneys detect that and they start producing the erythropoietin in the body. Released by the kidney, and then it responds to the hypoxic condition, and then that's basically how it goes. So what happens when you detect all these changes? So this is what we're talking about, right? These are the stimulus to release EPO. Decreased RBC count, decreased hemoglobin, or decreased oxygen level. Either one of them will cause hypoxic condition, and once that is there, the kidneys detect it, and then it starts producing EPO. EPO goes to your bone marrow, which is in the proximal epiphyseal region of your long bones or your flat bones, and it kicks in the hematopoietic stem cells to become more of the erythrocytes. So erythropoiesis increases, and then you have erythrocytes released into the blood and increases the oxygen carrying capacity, and hypoxic condition is normalized basically. So this is a negative feedback mechanism mainly. Okay, this is the hormonal control that you have. So if you have EPO less, like for example, kidney diseases, so EPO is not formed because the kidney is not functioning properly, then you are going to see hypoxic conditions. So people who are in dialysis, they will probably see hypoxic condition constantly. So they need to be given artificial EPO so they have enough erythrocytes so they don't go into hypoxic condition. Now, EPO is also consumed by athletes to increase the erythrocytes so they can increase the oxygen carrying capacity to the muscles. It is illegal in many sports. The problem with this increasing your RBCs is the amount of RBC determines the thickness of your blood. So if the RBC count increases, the blood becomes really thick and sticky. So if your blood becomes thick and sticky when your RBC counts go up due to you taking artificial EPO, that means you are prone to having clots. So an athlete not only is getting dehydrated when they're working out, so the blood itself becomes thicker normally, and on top of it, if they take EPO, that's going to increase the RBC count, which doubles the effect of thickening of the blood, which increases the chance of stroke and heart attack and all that stuff. So that is the problem with taking artificial EPO in athletes taking them. Now, the second control that we have in erythropoiesis is dietary control. So, what is your RBC made of? It is made of protein, it's made of iron. So, if you have um, any of those dietary requirements less. So if you have not enough protein in your diet, not enough lipid to form the cell membrane, or not enough iron in your diet, then you're going to have problem with erythropoiesis. Iron itself, freely floating iron, is toxic to our body, so they have to be stored with some sort of protein, the alpha and beta globulin that we talked about earlier. So it binds to those proteins. These proteins have specific names. So if you see a stored iron, it's a ferritin and hemosiderin. If you look at it in a transportation mode, it binds to a protein called as transferrin. So that's very important. Apart from all of these, you also need B12 or folic acid. Any dividing cells where the DNA is dividing, it requires for DNA synthesis your folic acid and B12. So in absence of that, the cells do not divide properly and leads to larger cells. So that basically leads to some sort of issues later on. We'll discuss it. So these are the important dietary requirements that you need for your erythropoiesis: amino acids, fats, and lipids. Normal, any developing cell, multiplying cells need these. And then our iron, especially for your RBC, and then finally your B12 and folic acid for your DNA synthesis. Like I said earlier, lifespan of your erythrocytes is 100 to 120 days. So what happens after that 120 days? So what is the fate and destruction of erythrocytes? So for that, let's look at this picture that you have in your textbook. I'm going to enhance it a little bit, starting with, oops. Um, so let's kind of look at what happens to hemoglobin, right? So it's aged, the 120 days is achieved. So now what happens? The hemoglobin, the graveyard of erythrocytes, is considered as spleen. Doesn't have to go to spleen all the time, but that's basically normally where all the hemoglobin or RBCs goes to die. So that's why it's called as graveyard of your erythrocytes. So because of the capillaries that are there in the spleen, it's easily shattered. The older RBCs are easily shattered because it loses the flexibility as it ages. Once it shatters, you have two components coming out of that RBC. Because RBC is filled with hemoglobin, 97%, we're going to talk just about hemoglobin, what happens to it. Heme component and globin component are separated. The heme basically is the main thing we're going to talk about. The globin being amino acids, protein, it's reused for different purposes in your body. Now let's look at the heme. The heme from the spleen is transported as bilirubin to the liver. The iron in the heme again binds to the protein and it's stored as ferritin or hemosiderin again in the liver, which is why liver, if anybody has tasted it, has metallic taste to it. So does kidney. So now let's look at the bilirubin. Bilirubin is picked up by the liver, and the hepatocytes in the liver converts the bilirubin into bile. Now, the iron that is stored as ferritin and hemosiderin basically is bound to transferrin and then released in the blood, where it goes to your red blood cell, red bone marrow, and reused for making more erythrocytes. Now, this bilirubin is converted into bile and then released into your intestine. Bile is actually an emulsifier for fat in our fat digestion. So it basically emulsifies the fat, and then the fat is broken down into smaller molecules and then easily absorbed into the lymph. Now, let's look at what happens to the bile. That bile, when it reaches the large intestine, it's broken down again by the bacteria in the large intestine into stercobilin, which gives the yellowness to the fecal matter. Most of the bile is actually reabsorbed into the blood and taken back into the liver. So 95% of the bile that is used for fat digestion is actually reused bile. So every day we make only 5% of new bile from the hepatocytes. 95% is the old bile that gets recycled. And then that 5% is what is converted into stercobilin that comes out in the fecal matter, which gives the yellowish color to the fecal matter. Okay, so this is basically how the hemoglobin is broken down and reused, and this is the fate of erythrocytes. Now, you might have heard of jaundice. Okay, jaundice is when you have yellowish color to your skin, your mucosal lining in your body. Now, most of the time, jaundice is related to liver disease. Now, why is that? Because if you look at it, the liver is the one that converts your bilirubin to bile. So if the liver is not functioning properly, then the bilirubin that is continuously made by the old RBCs that are shattering starts to accumulate in the blood, giving the yellowish jaundice. If for some reason you have hepatitis and all that, that's basically what's going to happen. But this is not the only reason that you end up having your jaundice in your body. Jaundice can happen if there are too much of RBC that is being broken down, that the liver cannot compensate to break down that bilirubin that's floating in the blood. So you end up with jaundice there. Jaundice can happen if the bile that is produced by the liver is not properly getting to the intestine, like gallstones blocking the pathway of bile to the small intestine. That can lead to spilling of it, that can lead to that as well. So the jaundice is caused by multiple diseases. It basically tells you there's either a lot of bilirubin or bile that's spilling out into the blood. Okay, that's just an FYI for you. Let's get back to, so just go over this picture for it. It'll be good. Um, the disorders. Now, the disorders, obviously, you're going to have two spectrum, right? You have one that's not enough RBC being made, and two, you have too many RBCs made. So the one that are not enough RBC made is called as anemia. The one you have too many RBCs are called as polycythemia. Now, anemia, it can be caused by multiple reasons, right? The definition of anemia basically tells you that there isn't enough oxygen carrying capacity in the blood. It doesn't basically support the normal metabolism that happens in the tissue. So the oxygen is not enough for the tissue in your body. Why is that? It can be because you have blood loss. It can be because not enough RBCs are produced, or because RBCs are being destroyed in a faster rate than it's been produced in your body. Okay, these are the three main groups of reasons that causes anemia. So let's look at blood loss. There are two kind of blood loss. You have the chronic one and you have the acute one. Acute, or it's a hemorrhagic anemia. The acute one is a rapid, like severe wound, trauma, those kind of things. You have to treat blood replacement. That's it. The chronic one is usually what you see in the doctor's office. Chronic is because there's slow amount of blood loss continuously in the body. So you're not reusing the iron, you're not reusing the globin, you're not reusing the heme, bilirubin. So everything is lost in the body. So there's going to be a severe shortage of iron and globin and heme and those kind of things. Your body has to remake it all from scratch once again. So that is what's the problem with chronic hemorrhagic anemia. Now, what causes this? Ulcers, mainly hemorrhoids, fissures, anal fissures, those kind of things that are microscopic bleeding that happens in the body leads to chronic hemorrhagic anemia. So you have to fix this to treat this type of anemia. The next group of anemia is caused by not enough RBC being produced. So RBC production, that is erythropoiesis, depends on hormonal control and also dietary requirements. So both of them can cause not enough RBC being produced. So EPO, which is due to kidney diseases or dietary requirements. So that means you have not enough iron in your food, not enough B12 in your food. Those kind of things also lead to not enough RBC produced. Now, iron deficiency anemia is very common where you're not eating enough, iron intake is not there, or it's not being absorbed in your body. Now, without iron, hemoglobin, the heme component, is not enough to make RBC. So your cells are going to be smaller. Iron deficiency anemia is also called as microcytic anemia because the RBCs are smaller than 7.5 micrometer in diameter. They're smaller and paler in color as well because they lack iron. So you have to give iron supplements. So, chronic hemorrhagic anemia can eventually lead to iron deficiency anemia as well. So, you have to fix the bleeding, chronic bleeding, and then give them iron supplements to kind of treat both of these type of anemia. Now, pernicious anemia is kind of the autoimmune disease anemia, in which your stomach mucosa is destroyed, and the stomach's lining is what produces what we call as intrinsic factor that helps in B12 absorption. So, like I said earlier, B12 is for DNA synthesis. Without that, the cell cannot divide properly. So, in this type of anemia, pernicious anemia, B12 deficiency anemia, you have macrocytes formed. So the cells, RBCs, are larger than 7.5 micrometer. So you're going to have macrocytic anemia when you have pernicious anemia. Um, in this case, you need to give B12 injections to people who have the stomach lining destroyed and not enough intrinsic factor being produced. Because if you give B12 tablets, it doesn't matter because the intrinsic factor is not enough and it won't absorb that B12 that you took in the tablet form. So you have to give injections or nasal gel in the case of these autoimmune diseases. So what happens over here is vegetarians can cause it, so they might not have intrinsic factor deficiency. They might be just low in B12. B12 is seen in a lot of animal products, so vegetarians, vegans, they usually end up with this kind of deficiency. They can take the B12 tablets because their intrinsic factor is normal. It's just lacking in their diet, basically. Next type of anemia where RBC is not produced enough is the renal anemia, where I told you the hormonal control portion that controls the erythropoiesis is not enough. So the kidneys are not functioning, it's not producing EPO when even after detecting the hypoxic condition. So you have to treat it with synthetic EPO. So when a person is in dialysis, they probably should be also in synthetic EPO. Next, you have aplastic anemia, which you usually see in cancer patients where they're zapped, a radio therapy or chemotherapy is given. They zap the entire bone marrow that they have because they're all cancerous cells. So they have aplastic anemia. Pretty much all formed elements are in shortage when they have aplastic anemia. Okay, they have to undergo transfusion or stem cell transplants eventually. The next group of anemia, we talked about blood loss. We talked about not enough RBC produced. Now we're talking about a lot of RBC being destroyed compared to how much it is being produced. So, what causes the destruction of RBC? Main thing is the shape of RBC. So, if the shape is not maintained properly, then when it goes through the tiny capillaries, it's going to squeeze in and it's going to shatter. So what determines the shape? It basically is determined by the protein, like I said, the spectrin and hemoglobin abnormalities. So when you look at the hemoglobin abnormalities, it's usually genetic issues. So you have thalassemia and sickle cell anemia. Thalassemia is seen in Mediterranean ancestry, so you see in a lot of European, and also you see in some of Southeast Asian population as well. In this type of thalassemia, it's the globin chain that is faulty or absent completely, so the RBC becomes thin and delicate, and it's deficient in hemoglobin, and it shatters pretty fast. There are different types of thalassemia. If it is mild, you're fine. If it is severe, then you probably have to take blood transfusion. Sickle cell anemia is seen in African descendants where the hemoglobin is mutated. The chain of the hemoglobin, the amino acid chain, you have one amino acid that switched for the other, with which causes the sickling of the RBC in hypoxic condition. So when you're working out, when you're climbing higher altitude, it's going to start sickle. The reason why you see an African descendant is it's kind of like evolutionary aspect that happened to protect the people against malaria. So malaria is a parasite that likes to finish its life cycle in the RBCs and then burst open and comes out and infects a new one. So, in order to prevent the life cycle of the parasite finishing in the RBC, this type of mutation has happened in the African descendants, where in your hypoxic condition, it starts sickling the RBCs, and when the RBCs sickle the plasmodium, it's not able to finish its life cycle, hence, you do not get malaria. That is the reason why people have this type of mutation. The hemoglobin that you see in this mutated RBC is called as S hemoglobin, mutated hemoglobin, where one amino acid is switched for the other. The problem with sickling of these RBC is that even when you work out, they're going to sickle, and when they sickle, they become sticky and they form clot and block tiny capillaries, leading to loss of blood supply to that part of the body, which leads to pain and blockage of small vessels and all that stuff. Um, so that is basically the importance of this mutation. Now, sickle cell anemia can be treated acute crises by transfusion, inhalation of nitric oxide. Nitric oxide is a vasodilator, so when your blood vessels dilate, the clot kind of moves and the blood circulation restores. Or you can also use preventative methods like hydroxyurea, stem cell transplants, and gene therapy, and nitric oxide and all. So if you look at this, this is sickling. So what you're seeing over here, right here is a sickling, another sickling cell, sickled cell. Here's another classic sickle cell. So instead of nice and round RBC, you have these kind of sickled cell RBCs in your hypoxic condition. Um, so that is your sickle cell anemia, and we have finished the anemia. Now we're moving on to polycythemia, the other end of the spectrum of the RBC disorder, erythrocytes disorder. This is where you have too many RBCs in the body, in the blood vessels, and because there are too many RBCs, it increases the viscosity of the blood, which increases the clotting of the blood. So the blood flow becomes really thick. Um, there are two kind of polycythemia. One is vera and one is secondary polycythemia. Vera is usually due to bone cancer. They have high levels of RBC. And the treatment is you just let the blood out. So therapeutic phlebotomy is what is usually done in polycythemia vera. The secondary polycythemia is where something else is causing high levels of RBC. So it can be because you went to higher altitude somewhere for a long period of time. So after 7 days, normally, because there's less oxygen in higher altitude, your kidney starts to producing EPO and erythrocyte count goes up. So you try to compensate for the lack of oxygen in your body by making more RBC and capturing whatever oxygen is in the air that you breathe in. So that can lead to secondary polycythemia, or even people who have um, people who snore at night. So snoring basically is temporary cessation of breath. So when you're stopping your breath while snoring, you're going into hypoxic condition. That's triggering EPO, which then leads to polycythemia, and that is your secondary polycythemia as well. Or taking artificial EPO, like for example, athletes who take that. Blood doping. That also causes polycythemia, secondary polycythemia. So in this table that you're seeing, you're basically looking at all the different shapes of RBC. Based on the different shapes of RBC, you can actually associate what type of diseases a person might have. So what you're seeing over here is microcytic iron deficiency, macrocytic B12, the Burr cell, Spur cell. This is basically having spikes on the cell membrane of the RBC that can be multiple issues, mainly liver disease because it's a protein. And then you have the target cell over here, thalassemia. You see that because it's kind of concentrates in the middle as well. Sickle cell, we talked about that as well. Um, so you can just go over the rest of it and see how the shapes can determine what type of diseases you have. Um, Leukocytes is white blood cells. There are different type of leukocytes that we have in our body, and each one has different functions. Total amount of WBCs that we have in our body is about 11,000 WBC per microliter of blood. So it comes to about less than 1% of the total blood volume. Now, the importance of leukocytes or WBC is that it is a complete cell. So it has all the organelles, it has the nucleus, everything else, and plus it has unique capabilities of certain WBCs have capability of squeezing through the gaps in the capillaries into the tissue and wandering in the tissue and in basically engulfing the invaders like bacteria or any other toxins that might be there in between the tissue. So it has the leaving capillary capacity, it's called as diapedesis, and moving through the space in the tissue called as amoeboid motion and goes towards that particular bacteria or chemical that it has to engulf. That's positive chemotaxis. Okay, so this is very important for defense mechanism in our body because not every your body doesn't wait for all the bacteria to enter the blood before it can attack. At that point, it'll become too late. So it has to preemptively attack before it enters the blood circulation. And that's what our BCs are capable of doing. So as soon as the skin is penetrated and the bacteria enters the tissue, you have these WBCs squeezing out from the blood into the tissue through diapedesis, moving through the tissue through amoeboid motion towards the bacteria or chemical that has to be engulfed we're using the positive chemotaxis mechanism. We're going to see that more in the immune system later in this course. Um, Leukocytosis definition, what is it? Normally, if you have an infection, you have a normal response by increasing the amount of WBC that is leukocytosis. It is not leukemia. Leukemia is an abnormal where the cells are immature and non-functional. This is functional cells that are increased to fight off infection. That is leukocytosis. When you look at the different types of WBCs, you can categorize them into based on whether they have granules in the cytoplasm or not. If they have granules in the cytoplasm, they're called as granulocytes. There are three of them, neutrophils, eosinophils, and basophils. If they're absent, the granules absent, they're agranulocytes. There are two of them, lymphocytes and monocytes. So you might want to know the structure of all of these different types of leukocytes and their functions as well for your test purpose. Now, how much percentage of all of these different types of leukocytes are found in your circulating blood? So when you look at the granulocytes, neutrophils are the highest amount that you see. Those are your primary response for defense that you get. So it is 50 to 70% of your WBCs that belong to neutrophils. And then you have eosinophils, which are only 2 to 4%, basophils, which is the least of all, 0.5 to 1%. I'll tell you why later. And then you have agranulocytes. The next second highest is your lymphocytes, which is your 25 to 45. There are two kind of lymphocytes that we have: B lymphocytes that produces antibody, and T lymphocytes that helps in killing viral infected cells, mutated cells, cancer cells, or transplanted cells. Those are your T lymphocytes. So you have them together, B and T, 25 to 45% in your blood. And then monocytes, which are 3 to 8%, these are the ones that squeeze out of the blood and goes into the tissue and kind of patrols the tissue for any invaders. Let's start with your granulocytes first. They are larger, shorter lived than RBC, and their nuclei are usually lobed, meaning they're not nice and round. They're kind of multiple lobes that are there, and the granules stain accordingly. Now, neutrophils. Why are they called neutrophils? Because they contain both acidic and basic dye granules. So basically, when you stain these cells, the granules are both blue and red. So when you look under the scope, when you look at them, you're going to see these granules kind of like this. So the granules are going to be like pale red and blue cytoplasmic granules that you're going to see. The other important thing that you're going to notice in the neutrophils, they're abundantly there. So if you look at a blood smear slide, you're going to see a lot of them because this is the highest amount that you see in your circulatory blood. So you're going to see a lot of them. And then if you look at the nuclei, they're multi-lobed. So they're considered as PMN or polymorphonuclear leukocytes because their nucleus are so many lobes. They're anywhere from 3 to 6 lobes. The function of neutrophil is phagocytic in nature. Again, there are a lot of them found in the circulating blood. So they are the first one that goes there. So they're bacterial slayers. They engulf the bacteria, and then the lysozymes that are found, the granules that are found in the cytoplasmic granules that are found in neutrophils, they basically cause these bacteria after engulfing to release what is called as respiratory bursts, which means it has hydrogen peroxide, it has bleach, it has all these things in the granules that are released onto this bacteria that was engulfed and then digest that bacteria. So that is basically the importance of your neutrophils that you have in your body. The next type of granulocytes you have is eosinophil. Eosinophil because the granule stains red. So 2 to 4%, that's what you see. You can see the red granules. And if you look at the nucleus, there are bilobed. So they're bilobed nucleus and red staining granules. So what do these granules contain? They contain digestive enzymes that has the capability of digesting parasitic worms. So any kind of worms, they don't actually go inside the worms. They basically release those granules out onto the worms and this dissolve the outside layer of the parasitic worm in your body. They are also responsible for allergic reaction and asthma. Asthma used to be called eosinophilia because the high levels of eosinophils that are seen in asthmatic patient, that condition was called as eosinophilia. Um, so it plays an important role in allergies and asthma as well. So that is your eosinophil. The last granulocytes that you have is your basophil. Basophil because the stain, the cytoplasmic granule stains blue. They're large granules, dark blue granules that almost cover the nuclei. We don't see the nuclei because of that deep purple granules that are seen. The nucleus is bilobed in this one most of the time. One or two constrictions are seen. It's only 0.5 to 1%. I said I'll tell you why they're so least and rarest of all WBC because these granules contain histamines. Histamines are responsible for inflammatory reaction. You don't want inflammation going on in your body because once inflammation happens then all the other organs also starts reacting, so you don't want that many inflammation. So this is the reason we have basophil the least. It has histamine chemical that causes inflammation in them. So it goes mainly to any kind of, say for example, you have insect bite. Insect bite releases the toxin in the tissue, so as soon as the body detects that, the basophil goes over there and blast cells that are there also sorry, not blast cells. Mast cells that are there also release this histamine along with the basophil, and then inflammation happens, which is what causes the bulging that in the insect bite area. What does inflammation do? It basically contains that toxin in that area, and it also helps in healing of the area. So that's the reason why we have the inflammation in the body. And for that, you need basophil. But if inflammation happens throughout the body, then it ends up with, like, for example, where you have to use EpiPen, where you have the inflammation happening in the larynx and you can't breathe, anaphylactic shock. That basically is also an inflammation. You don't want that. That's why you have least amount of basophil in your body. We're moving on to the agranulocytes. There are two of them, leukocytes and monocytes. Um, Not leukocytes, sorry, lymphocytes and monocytes. Lymphocytes are two. There are T cells and B cells. T cells, once again, viral infected cells, tumor cells, or transplanted cells. Those are the ones that are attacked by your T lymphocytes. So whatever is hiding inside the cell, like virus, or mutated cell like cancer cell, or transplanted cell that does not belong to you, will be attacked by your T cells. B cells, on the other hand, produces globulin, immunoglobulin, so or your antibodies that are usually there to tag or neutralize the toxins that are in your blood. So here's a picture of your lymphocyte that you have. It's a small cell, but because it's so small, you have very less cytoplasm in it, and the nucleus take up the whole area, and the nucleus basically has a small indentation, and a thin blue rim of cytoplasm is seen in your lymphocytes. Monocytes are the largest cell that we have, 3 to 8% of it. This is the one that actually can go into your tissue. They are permanent resident in certain type of organs like your liver and your lungs and your brain as well, where they permanently are found in there. When they leave the blood and into your tissue, it's called as macrophages. They're voracious eaters, so they can engulf viruses, their phagocytic cells, or bacteria, or any toxins, or anything like that, or dead cells, whatever is there, they can eat up phagocytic cells just like your neutrophils are. But this one, macrophages are way higher efficient than your neutrophils in your body. Okay. This is your monocytes. So you, again, agranulocytes, nucleus with kidney-shaped nucleus with indentation. And that basically concludes all the different types of leukocytes I have in your body. So once again, what does it look like? What is its function? How much percentage is it found in your body? So that's all what you need to know for your uh, test when you're studying. Let's move on to leukopoiesis. Leukopoiesis is formation of WBCs. Now you have so many different types of WBCs. So how does the body know which one to produce, which one is needed? For example, you need only eosinophil. You need those granulocytes to be produced. You don't need agranulocytes to produce because you have or inflammation or parasitic worm found in your body. So for that, you need interleukin and colony-stimulating factors, which basically stimulate only a certain type of colony in your bone marrows. And interleukin are chemicals that are produced by different type of cells. There are different kinds of interleukins that are there, which trigger certain type of WBC to be produced in your body. So with the help of these two, we can narrow down which type of WBC is needed to be produced in your body based on the immediate need. So you're not wasting your resources on making something that is not going to be used in the body. When you look at leukopoiesis, there are two branches, pathways that can be formed. One is the lymphoid stem cell pathway, and the other one is myeloid stem cell pathway. So if you look at this picture, it basically summarizes everything that you need to know. Myeloid stem cell over here and lymphoid stem cell over here. So under myeloid stem cell, the hematopoietic stem cell divides into two stem cells, myeloid and lymphoid. Myeloid, you have all of your granulocytes and your monocytes formed. In lymphoid, only lymphocytes, the B and T lymphocytes, are formed through the lymphoid stem cells. So when a person has certain type of leukemia, you can figure out which type of stem cell is being produced in higher level and what type of leukemia that patient has. So let's look at this myeloid stem cell. You have your myeloblasts formed. Now you have granulocytes, right? So you have granules in different type of granulocytes. Those have to accumulate, right? So you have like promyelocyte over here, and then eosinophilic myelocyte, basophilic myelocyte, neutrophilic myelocyte, and then band cells, because all of the nucleids are looks like kidney shaped, so band cells, eosinophilic, basophilic, and neutrophilic. And from there, they become the mature type of granulocytes. Now, for your monocyte, they are agranulocytes. So for monoblast, it becomes promonocyte, and from there, it becomes monocyte. And from there, when they leave the tissue, when they leave the blood into the tissue, they become macrophages. Now, lymphocytes, lymphoid stem cell, you have T lymphocyte and B lymphocyte precursor. From there, you have T and B lymphocyte made. B lymphocytes become plasma cells, and T lymphocytes becomes effector T cells. So if you go over this picture, that should be enough for your test purpose. Now, any kind of issue that you have, like hormones, EPO, or colony stimulating factor, those are basically is what is used clinically. They can stimulate the bone marrow in any patient, like cancer patient after chemotherapy and those kind of things, or AIDS patient where they have to increase the certain type of T lymphocytes in your body. Overproduction and underproduction, those are the two lymphocytic, leukocytic disorders that you have. Overproduction is your leukemia, infectious mononucleosis, and underproduction is leukopenia, which is usually after radiation or chemo drugs that are taken, or glucocorticoids where it suppresses your immune system. Let's look at leukemia. It's a cancerous condition. You have a lot of WBCs in the bone marrow as well as in the circulating blood. Now, these WBCs are abnormal, immature. They do not protect you. They overcrowd the red bone marrow, which means they do not allow RBCs and platelets to be formed. So you not only end up with infections because they're abnormal, immature WBC, but you also end up with anemia and clotting disorders. So bleeding disorders are found in leukemia. Usually the first stage where you go before diagnosis is when a patient becomes sick often sick with cold, fever, those kind of things constantly coming. That is the main key for any leukemia. And they also bleed a lot, even with minor scratch, because the abnormal cancer cells are not allowing more platelets to be produced, and they're anemic because, again, erythrocytes are also being crowded out by these abnormal WBCs. Leukemia is based on what kind. You can classify them as acute and chronic. Acute is usually from stem cells and it's fast advancing. That's why it's acute. Chronic is slow advancing, usually seen in older people and later stages of your leukopoiesis. So that's what you classify leukemia as. Without treatment, obviously, it's fatal because it's you die of some sort of infection mainly, or bleed to death as well. So you have to treat it. Now, treatment depends on what kind of leukemia you have. You can do irradiation to radiation therapy, cancer drugs, chemotherapy. Stem cell transplant is the ultimate one where you basically give new stem cells to the patient. The next one you have is your infectious mononucleosis. Now, this is not monocytes that are high. It is a viral infection, highly contagious, called as kissing disease. So if you kiss somebody, you're going to get that because it's caused by Epstein-Barr virus. It's a result of agranulocytes. High number of agranulocytes involves lymphocytes. Even though it says mononucleosis, where it makes like monocytes, the cells are so big, which is where the name came from. They looked at the large cells, they thought it was monocytes, but actually it's your B lymphocytes that are enlarged and looks as big as monocytes, which is caused because of Epstein-Barr virus. There is no treatment per se for this. You just take rest and a symptomatic treatment. Take some kind of aspirin or something for your fever and aches, and that's about it. After 4 6 weeks, you get cured. Um, we finished with WBC and RBC. Now we're moving on to platelets. Platelets are tiny formed fragments of a larger cell called as megakaryocytes. These fragments of these larger cell contains granules in them, which is capable of producing clot when needed. So if you look at what kind of chemicals these granules contain, they're serotonin, calcium, enzymes, ADP, platelet-derived growth factor for healing after clotting. So those are basically what are found in these areas. Now, normally platelets are kept inactive because of intact capillary walls. When you don't have any damage to the capillary walls, they're very, very smooth. They're called as endothelial lining. They're very smooth, and they also produce nitric oxide, which is part of vasodilator and also keeps the platelets in its inactive form. They also secrete a chemical called as prostacyclin, which keeps the platelets in an inactive form. Once this endothelial lining of the capillary is damaged, now why would it be damaged? You have a cut or you have high levels of um, fat floating in free fat because you're stressed. Now you have fatty plaques there, and those kind of thing damages the endothelium. Once the endothelium is damaged, nitric oxide and prostacyclin is no longer produced. The platelets in that area becomes active and they start forming clot. That's how plaque starts to form inside the intact blood vessels, just because the endothelial lining is not intact any longer. So let's look at the platelets themselves. They're regulated by like erythropoietin, you have thrombopoietin for platelet formation. The large cell that it starts off from is called as megakaryocyte, stage 1. They're all called as megakaryocyte in different stages. There are about 400,000 platelets per mil, degenerates every 10 days. So you don't even know that you have small type of damage that happens throughout in your body because your platelets are constantly clogging and clotting them inside. In absence of platelets, you will end up with internal bleeding in your joints, inside your GI tract, and you'll eventually bleed to death, or in your brain, those kind of things as well. So here's your platelet formation that you have. You start off with the same hematopoietic stem cells, and then you have stage 1 megakaryocyte or megakaryoblast, which is the committed cell. From there, you start accumulating these small, tiny chemicals. You start vesicles that are formed in stage 2 and 3. And then you have stage 4 where you have a lot of cytoplasm with a lot of these vesicles with all the chemicals that I mentioned earlier. The megakaryocytes are too big to enter the circulatory system because the Capillaries in your bone marrow are too small for your megakaryocytes, so they kind of like a cheese grater shreds the megakaryocytes, and tiny fragments of these large cell starts to enter the blood circulation, which are what we call as platelets. Now, these fragments of the cytoplasm of your megakaryocytes contain these vesicles, the chemicals that are needed for the clotting mechanism in your platelets. Okay, so that is your thrombopoiesis or platelet formation. Now, the main thing we're going to focus on the platelets is obviously its function, clotting. So hemostasis. Hemostasis is a general term for stopping of your bleeding. But if you look at hemostasis, there are actually 3 steps to it. The first step is vascular spasm, second one is platelet plug formation, and the third one is the blood clotting itself. So you have 3 steps that are there for hemostasis process. The first step is vascular spasm. As soon as there's an injury to the capillaries, the chemicals that are released from the injured tissue, and as well as the pain reflexes and the direct smooth muscle injury that happens causes vasoconstriction in that area. So that is vascular spasm. That's the first step of hemostasis. Please make sure that you keep the terminology straight. Hemostasis is blood stoppage. Okay. Coagulation is the third step of hemostasis. Okay. So first step is vascular spasm, which is vasoconstriction that happens to the as soon as the damage of your capillaries take place in your body. Chemicals released by the damaged cells, pain reflex, and the injury to the smooth muscles causes this thing. Now, you cannot, like for example, you cannot put tourniquet forever and just leave it in a patient, right? You have to go and fix that. So that's the next step. You cannot leave the capillaries in just vasoconstriction mode. It has to plug it. So that's where platelet plug formation happens. Now, platelets normally are in an inactive form because the endothelial lining of the capillary releases nitric oxide and prostacyclin and keeps it in its inactive form. We mentioned it earlier in the chapter. Now, the capillary has been damaged, so that means it's not producing NO, nitric oxide, and prostacyclin, which means the platelets is no longer inactive. Now, all of a sudden, it becomes active. When it becomes active, the platelets stick together and they clump up together. So sticking of the platelets, swelling of the platelets, and sticking of them causes this platelet plug formation. Okay, ADP from the platelets are released and causes platelets to stick, and then serotonin and thromboxane A2 enhances the vascular spasm and platelet aggregation. All of it as a chemical messenger that are released when you have tissue damage happening. Now, aspirin is the drug that blocks the thromboxane A2 and prevents platelet plug formation, which is why older people usually take those baby aspirins, which prevent this platelet plug formation, which means prevents clotting eventually. So this is a positive feedback mechanism where you see, so here's your platelet plug formation right here, where until you close that damage that is being exposed, you keep forming more and more platelet plug in that area. Once that area plug is fixed, then it stops. Okay, this is a positive feedback mechanism. Now, this plug is also temporary. You have to move on to the third step of hemostasis, which is coagulation. This is where the fibrinogen that's floating in its inactive form in the blood is converted into fibrin. Okay, that is the coagulation process. Now, the coagulation has 2 pathways. One pathway is called as intrinsic pathway and the other one is extrinsic pathway. Now, blood clotting, blood coagulation can happen even outside the body, right? If you take some blood and you cut and small blood drops onto the surface, that blood that falls onto any surface also clots. Okay, so you don't need basically a tissue in order to be damaged and form blood clotting. It can happen either way. So that's why you have two pathways, intrinsic and extrinsic. Extrinsic is where you need a damaged tissue. It's much faster because we know that there's a damaged tissue, so it has to bypass. There's a lot of steps that are not there in extrinsic pathway, and it's much faster. Whereas intrinsic pathway, intrinsic within the blood, all of the chemicals for clotting are found within the blood, which is why you see blood clotting outside the body as well. Okay, so there are two pathways that you have in phase one, intrinsic and extrinsic. All the clotting factors which helps in clotting are found within the blood. Extrinsic, it needs a tissue factor, TF, factor 3, in order for the clotting to happen. It's outside the blood, hence extrinsic. Okay, so this is the first phase. Again, coagulation has three phases. Hemostasis has three steps: vascular spasm, platelet plug formation, and coagulation. Coagulation has three phases. You have phase one, which has two pathways, intrinsic and extrinsic. And then phase two we'll look into eventually. So here's the phase one that you're looking. Intrinsic pathway that has a lot of clotting factors, which are used as Roman numerals. These Roman numerals indicate different clotting factors, which are nothing but proteins made in your liver. They have been identified in different kind of different way. So whichever was identified first, it got number one, and the last one, number 12, number 13, those kind of things. Um, so these are all the different clotting factors that you see in the intrinsic pathway. And look at the extrinsic. Tissue damage is all it needs. Tissue factor is all it needs. Not that many clotting factors, which is why it's much faster. It doesn't matter which pathway the phase one takes. Ultimately, you produce what we call as prothrombin activator. And that is basically the end of phase one is formed. This prothrombin activator converts prothrombin into thrombin. That is the end of phase two. The thrombin, in turn, goes in and helps in converting the fibrinogen into fibrin and forming the cross-linked fibrin mesh, which is what blood clotting is all about. That's end of phase three. So it doesn't matter which pathway the phase one starts, either intrinsic or extrinsic, both of them produces prothrombin activator at the end, which then leads to phase two, which forms thrombin, which then thrombin goes and activates the fibrinogen into fibrin and then helps in formation of fibrin mesh, which is nothing but this, which traps all the RBC and kind of, because of the myosin that's in the platelets, it brings the fibrin mesh closer and tighter together and seals the end of the damaged capillary and prevents blood loss. This is the final blood clotting that you have, the final step of hemostasis that you have in your body to prevent blood loss. So you might want to go over all of these phases. You don't have to pay so much attention to the clotting factors and different phases, because I don't think I'm going to ask questions on that. But if you want FYI, here are all the clotting factors that you have in your body and its functions that are there. Now, if somebody is missing a clotting factor, it leads to hemophilia. So you have different types of hemophilia based on which type of clotting factor is missing in that patient. Okay. What happens after the clot is formed? You need to have retraction and fibrinolysis happening at the same time. So what does that mean? What is clot retraction? It kind of brings it together. So it's not just loosely formed fibrin mesh. It tightens up because of the myosin that are in the platelets. Myosin that you saw in your skeletal muscle, same myosin, actin myosin. It brings it together and squeezes out the plasma minus the clotting factors, which is what we call as serum, happens within 30 to 60 minutes. Why do you have to pull the ends together? Because it helps in healing process better and closes the opening is much closer than it is normally. What happens afterwards? Now, it is not enough if you just seal the opening, right? You have to initiate the healing process. So you have platelet derived growth factor in your platelets that actually help the division of smooth muscles and fibroblasts to rebuild the blood vessel wall. And then you have vascular endothelial growth factor to help the endothelial lining to rebuild as well. And then you start with fibrinolysis. So once that has happened, the clotting is done, you want to remove the clots after repair is complete. Begins within 2 days. You can't have clot forever in your life, right? That has to be removed. That is by fibrinolysis. It lyses the fibrin. What lyses the fibrin? Plasmin. So you have plasminogen, which is again an inactive form of protein that is converted into plasmin, and that plasmin it was digests the fibrin eventually. So a stroke patient where the clot is being formed is given the tissue plasminogen activator, which is converted into plasmin and start eating up the clot. The faster you give the TPA to a stroke patient, the lesser damage they're going to have in the brain. Okay, that's your fibrinolysis formation. Now, why does the clot, because it's a positive feedback mechanism, why does the clot always stops in the area of damage? Why doesn't it just continue throughout the blood vessel, even in the normal portion of the blood vessel? It's because of this. One, it quickly removes the body quickly removes the clotting factor and dilutes them. And two, it inhibits the activated clotting factors quickly, preventing the clot size to be more than necessary, to be larger than necessary in your body. Okay, so these two mechanisms limit the clot size to the damaged area only. Okay, so that is important in your body. And then you also have antithrombins in your body that binds to the thrombin, the fibrin threads that are there, so it doesn't move somewhere else in the body and forms a clot over there. So antithrombin inactivates the unbound thrombin that are there, that escapes to the bloodstream and helps to remove all that so the clot doesn't go anywhere else. And so does heparin from basophil and mast cells as well. Okay. Um, Factors that prevent platelet adhesion or prevents undesirable clotting. So that again, it's the same thing that prevents undesirable clotting, keeping the endothelial lining of your blood vessels smooth. It produces nitric oxide, it produces prostacyclin and vitamin E. All of these are potent anticoagulant and they prevent unnecessary clot from forming. Which leads us to the hemostasis. You have too much of clots, unnecessary clots, or too less of clots, bleeding disorder. So you have thromboembolic disorder, undesirable clots that are formed, or not enough clot formed, bleeding disorder in your body. And you have the third variety in your platelets, which is disseminated intravascular coagulation, DIC, which basically you have initially a lot of clots, you deplete all the clotting factors, and then lead to bleeding disorder. So you have initially thromboembolic disorder, which then leads to bleeding disorder together in a patient. That's DIC that you see. Let's look at thromboembolic condition. What is thrombus? What is embolus? What is embolism? You might need to know the definition of it. Thrombus is when the clot is formed in an unbroken blood vessels. So you have a clot that's formed, no broken vessel. You just form it and it blocks that blood vessel, leading to the tissue death. That's thrombus. If that piece of thrombus peels off from the site that is formed, floats freely, that is embolism. And the condition when this embolus blocks an organ is embolism, obstructing a vessel like pulmonary embolism or cerebral embolism. The risk factor of this kind of thrombus and embolus formation is atherosclerosis, inflammation, hemostasis due to immobility, a long term, like sitting in a like a I don't know, 14-hour airplane ride that you have, or sitting from dawn to dusk playing video games, or truck drivers, those kind of things, standing for too long period of time doing surgery, for example. All of those can lead to this thrombus formation. And once you start moving, that thrombus becomes embolus and causes embolism. Okay, what do you do in this condition? Once you notice that there's undesirable clots that are being formed, thrombus being formed in the body, you start to dissolve that clots. So you want to give anticoagulant like aspirin, heparin, and warfarin. Like I said earlier, aspirin basically is thromboxane A2, heparin, antithrombolytic agents, and same for warfarin as well. Bleeding disorder is thrombocytopenia where you do not have enough platelets, usually caused by cancer, blood cancers of different types, or treatments for blood cancer where you destroy all of the bone marrow cells, leading to this kind of condition. So it can lead to small broken capillaries underneath the skin, leading to these pinpoint hemorrhages that are there called as petechia, which are easily seen in there. What other conditions can cause bleeding disorder? Impaired liver function because you don't have clotting factors formed. So you have hepatitis, cirrhosis, vitamin K deficiency, those kind of things can lead to that. Hemophilia, where there's not enough clotting factors, genetic disorder. So depending on which clotting factors, you have different types of hemophilia. You have to give clotting factors to these patients for their lifelong. You have genetically engineered clotting factors. They used to do blood transfusion, then they gave plasma, then they gave clotting factors only, but it all lead to transfusion diseases like hepatitis, HIV. So they started making their own clotting factors in the labs, and that's what they're giving for hemophiliacs nowadays. The last one is where you have both clotting and bleeding disorders together. This is DIC, which is usually happens when septicemia and incompatible blood transfusion, complications of pregnancy can lead to DIC in a patient. This is where you have widespread clotting and it blocks the blood flow to certain organs. And then because there's so much clotting happening in the blood, all clotting factors are used, which then leads to severe bleeding. So you end up with internal bleeding in the same patient itself. That's DIC. You have to have complete blood has to be let out, completely change. Clotting factors, anticoagulants have to be given in these patients so they don't have embolism later on. So those are the hemostatic imbalances of platelets. We've finished all the formed elements, structure, function, how is it made, and then homeostatic imbalances in each of the formed elements. The last portion of this chapter we're going to talk about is blood transfusion. Blood transfusion is, again, you can only have so much of blood loss in the body. After about loss of 15 to 30%, you end up with weakness. More than 30%, now you end up with severe shock. So in order to prevent the patient from going into severe shock, you end up with restoring the blood volume. If initially you need to know the blood type of the patient to give a proper blood transfusion. If you do not know the blood type and it's an emergency, the first thing you do is give them saline solution or Ringer solution and bring up the blood volume, and then balance out the formed elements. Then you can give packed red blood cells or RBCs or buffy coat, depending what is necessary in that patient. eventually. But initially, you want to bring up the blood volume, because if you don't do that, then you have kidney shutdown, then heart doesn't function properly, and every organ starts shutting down. So you want to increase the blood volume at once. Um, Blood transfusion, you can do whole blood transfusion, which is taking blood from one person to giving it to the other, or you can do packed red blood cells. You don't need plasma, you just need, they're severely anemic, you just need RBC, you give packed RBC. You can also give the Buffyco, where you're just giving the WBC and platelets to them. So it depends on what is needed for the patient. You can give just that instead of the whole blood. In order for you to do the blood transfusion, you need to know the blood type of the patient and the donor. So, what is blood groups? The blood groups are determined by the antigens that are on the RBC membrane. There are different kind of antigens. What are antigens? They're basically receptors that are found on the RBCs. So antigens are anything perceived as foreign that can generate an immune response. So RBC antigens are usually formed after you're born in about like couple of months, which is why a newborn does not get a blood typing, because the antigen hasn't been formed on the RBC. It takes some time. So these antigens are also called as agglutinogens because they promote agglutination when given to the wrong blood group patient. Okay, so mismatched blood transfusion causes these antigens, agglutinogens, to clump up together, causing agglutination. It's a fatal mismatched blood transfusion reaction. So, what kind of blood groups do humans have? There are 30 naturally occurring RBC antigens that are found in humans, but the most common type of antigens and blood groups that we have is ABO and RH blood groups. Okay, you also have MNS, Duffy, Cal, Lewis, but those are weak agglutinogens, usually not used until if the patient needs several transfusions, that's when they look for the other types. So let's start with ABO blood grouping. So each individual has a certain type of blood group. Based on what type of antigen is found on the RBC. What type of agglutinogen they have on the RBC determines their blood group. So if a patient has an A agglutinogen on the RBC, their blood type is A. If they have B agglutinogen on the RBC, their blood type is B. If they have both A and B, their blood type is AB. If they're lacking both A and B, they don't have either A or B agglutinogen on their RBC, their blood type is O. Based on what is on the RBC, their blood group will be determined by that. What the opposite of what is on the RBC is found in their plasma. The opposite, meaning if a type A blood group person will end up with antibodies in their plasma of type B. They'll have anti-B antibodies or agglutinins in their plasma. So, for example, if you have a type A patient, so here's your type A patients, right? Let's look at this one right here. A type A patient has A agglutinogen on their RBC, anti-B in their plasma. So if you give this patient B blood group, where the RBC has B antigen or agglutinogen, and they have anti-A in their plasma, what is going to happen? This anti-B is going to attack the RBC. Anti-A is going to attack the A. What will it lead to? Mismatched blood transfusion reaction. Okay, so this is basically what we're trying to avoid when we're doing the transfusion between two patients. Okay, so let's go over once again. If this is the RBC antigen, agglutinogens, okay, this determines the blood group that you have. Whatever is on the RBC will be the blood group. So here you have the RBC with both A and B. Because they have both A and B, they do not have any antibodies in their plasma. If they did have any antibodies in the plasma, they'll be attacking their own RBC agglutinogens, right? So you don't want that to happen. So they do not have any antibodies in their plasma. Now let's take B. B means they have B agglutinogen on their RBC and the opposite, anti-A in the plasma. So you have B on the RBC and anti-A in the plasma. Now for A, they have A on the RBC and anti-B in the plasma. And O, they do not have anything on the RBC, but they have both anti-A and anti-B in their plasma. Now, this will determine what kind of blood a patient can receive and who can they give their own blood to. So, for example, I am an O. I do not have any antibodies, antigens on my RBC, but I have both antibodies in my plasma. Usually, when you're donating blood, you end up with what? How many liters of blood do you have? Average 5 liters, right? You're going to give what? 1 liter of blood. So you're going to give a smaller amount of blood than you usually have in that patient. Okay, so I am an O. I am going to donate blood to, say, for example, a B patient. Okay, so what happens in this condition? I do not have anything on my RBC. My RBC is naked. There is no agglutinogen over there. So the anti-A has nothing to bind to. Okay, so I can give easily to B, I can give to A, I can give to AB. Hence, O blood group is considered as universal donor because they do not have anything on their RBC that these recipient antibodies can attack on. Okay, universal donor, I can give it to anybody. But if you look at AB blood group, they have both antigen. Okay, so if they try to give blood to an O blood group, I have both antibodies in my plasma. So I'm going to attack all of those antigen that's in that donor's RBC and kill all that RBC. Now you might ask, okay, why is, for example, I gave to A, right? So I gave to B actually. So I gave to B, all right? They have anti-A. I have nothing. I have both anti-A and B. Why didn't my anti-B attack their RBC? Because of the amount of volume of blood you give to a patient. I only give a liter of O blood group to possibly 4 liters of a B blood group patient. So I do not have enough antibodies in the donor blood to attack a recipient RBC. Do you understand what I'm saying? So that is the reason why my donor antibodies or agglutinins do not attack the recipient's antigen. Instead, you always have the recipient's antibody attacking the donor's agglutinogen. Okay, so let's clear everything off because I kind of messed it up for you over here. Let's clear all of this. And let's start all over again. Okay, so if a patient is B blood group, what all type of blood can they receive from safely? A B blood group, they have B agglutinogen on the RBC and they have anti-A in their plasma, which means you want a blood group where this anti-A does not attack. Okay, so what all blood group can that be? One, it can be B itself, okay, the same blood group, or it can be O, because O does not have anything on their RBC. Okay, so let's do another example that you can make sense of. I am an AB person. What type of blood group can I receive? Okay, AB has both antigen on their RBC, but no antibodies. Okay, there is no antibodies that can attack a, a donor's RBC agglutinogens, right? Which means AB is a universal recipient. They can receive from A, B, and O blood type. Okay. Another question, for example. Okay. What all blood can not O, A give to? What can they give to? Who can they give to? Well, I'm an A blood type. I want to donate blood. Who can receive my blood? Okay, that depends on your agglutinogen. So if I am A, which blood group will not attack my RBCA agglutinogen? Okay, let's see who does not have anti-A in them. Okay, I'm an A. Who do I give to? I can give to AB because they don't have any antibodies in their plasma, and I can give to A because I don't have any anti-A in my blood group. I cannot give to B, nor can I not give to O because both have anti-A in their plasma, which will attack my A antigen on my RBC. Do you understand that? So, who can you give to will be determined by what is on your RBC. Who can you receive from will be determined by what is in your plasma. Okay, so you might want to go over that once again and understand this. This table will explain pretty much everything that you need. Okay, now that was your ABO blood group. RH blood group determines whether you're positive or negative blood type. Most of population are positive, RH positive. What is RH positive? Meaning they have RH antigen on their RBC. RH negative is where they do not have RH antigen on their RBC. Now, unlike your ABO blood group, where after a couple of months you start producing these antibodies over here in the plasma, your RH, you have to first expose the body to the RH antigen in order to produce anti-RH antibodies. So you need to have two exposure of positive RH antigen in a negative RH person. You need two exposure of that RH antigen in order to produce anti-RH. So first exposure you get sensitized, and the second exposure you start attacking. So it'll be again typical transfusion reaction kind of scenario in the second attack. This RH blood grouping is very important, again, for blood transfusion, also for pregnancy. If a mother is RH negative, the father is RH positive, and the baby she's carrying is RH positive, the first pregnancy, the mother gets sensitized when the baby is born and during the labor, where there's mixing of fetal and placental blood. She gets sensitized to that RH antigen in the fetal blood. In the second pregnancy, when she's sensitized, what does it mean sensitized? She starts forming antibodies in her body against RH antigen. In the second pregnancy, where again the second baby is RH positive, then the RH antibody that was formed in the end of a first pregnancy, crosses the placenta, goes to the fetus, attacks all the RBC which has the Rh antigen on it, leading to what we call as hemolytic disease of newborn, erythroblastosis fetalis, which is a drastic effect in the fetal body. So how do you prevent this from happening? Before the mother gets sensitized, you give what is called as RhoGAM, which basically is anti-Rh and prevents the mother from getting sensitized to begin with. If for some reason the mother in the first pregnancy was not aware it was a home birth, it got already sensitized, she got already sensitized, then the second birth, if she goes to the hospital, if the baby is positive and the mother is negative and it's a second pregnancy, they have to do a complete pre-birth transfusion, exchange the blood of the fetus into Rh negative, and throughout the whole pregnancy it has to be done. And then after birth, basically, you can leave it later on. So that is the problem. So before, in the first pregnancy, if you give RhoGAM, the mother will not get sensitized and you will not have that erythroblastosis fetalis reaction. So what is transfusion reaction? It is when your mismatched blood is transfused, where the donor cells are attacked by recipients' agglutinins. So the antibodies in the recipient's blood attacks the donor RBC antigens, because once again, donor blood is less volume compared to the recipient's blood. So it is easy for the agglutinins in the recipient's blood to attack the donor cells and cause immense shattering of RBC, clogging all the small blood vessels, releasing massive amount of hemoglobin into the bloodstream, which goes to the kidney, leading to renal failure, kidney shutdown, and all of those things. And that is transfusion reaction that happens. It's very like you start off with fever, chills, low blood pressure, rapid heartbeat, nausea, vomiting, and then boom, you end up with that kind of a thing. So what do? You wash out the entire body, right? Preventing kidney damage with fluids, diuretic, wash every hemoglobin out, and then you give universal donor to them and bleed out all the other blood out of the body. That is basically what you have to do. Okay. So to prevent mismatched blood transfusion reaction, you have to do blood typing. How do you do blood typing? You take a patient's blood and then you do 2 drops of the blood, actually 3 drops, because you want to find AB, your blood group, and RH blood group. So you do 3 drops, and in each drop you put antibodies, anti-A, anti-B, anti-RH, and see which one agglutinates. Agglutination basically confirms what is on the RBC. So if anti-A agglutinates, that means on the RBC you have A antigen present. If anti-B agglutinates, on the RBC you have B agglutinogen. If RH agglutinates, then on the RBC you have RH agglutinogen. So agglutination is positive, positive for agglutinogen on the RBC. Anti-A, anti-B is agglutinins of the plasma that you're adding to the different blood drops. So whichever clots will tell you what's on the RBC. What's on the RBC will determine your blood type. So basically over here in this over here, what you're seeing is agglutination here. So they have both A antigen and B antigen. So the blood type will be AB. In this slide, you have only A agglutination in anti-A area, which means they have only A antigen on the RBC. There is nothing going on in the B. Over here, you have B agglutination, which means it has B agglutinogen on the RBC. And over here, none of it, which means it's lacking both agglutinogen on the RBC, which is type O. This is basically how you do blood typing. Okay. The last portion is blood tests. Again, if you need to know how well your body is functioning, you just do blood tests. Because blood carries everything in it. It carries hormone, it carries waste, it carries electrolytes. You can basically determine what kind of anemia you have, or WBC counts, whether you have infection or not, protein levels, different kind of protein levels, sugar, fat, the chemicals released by different cells, ALT, AST, everything can be checked by doing blood tests. Okay, so your entire body health can be determined by doing your blood test. Okay, so hematocrit value, blood glucose, leukocytosis, abnormal shapes of RBC, differential WBC count, prothrombin bleeding, bleeding disorder, platelet count, comprehensive medical panel, which basically gives the chemistry of your entire blood, what all chemicals it's carrying, CBC, different types of formed elements, hematocrit, hemoglobin level, everything can be checked by just doing your blood tests. The last portion is the developmental aspect. It is, again, a connective tissue, starts from the mesenchymal cells. In the fetus, you are not breathing, so you need to capture oxygen in a higher affinity. So you have fetal hemoglobin there, higher affinity for oxygen, and right before birth, it becomes a hemoglobin A, adult hemoglobin after birth. Aging diseases, leukemia, anemia, clotting disorder, those are all things that are found. So this basically concludes this chapter. I strongly urge you to go over the hemostasis of platelets, different types of anemia, and also you need to know the different blood grouping and what is on the RBC and what's in the plasma, and keep it say who can donate blood to who can receive blood from whom. Those are all there. There's a lab that you'll also be doing on this blood typing as well. So we're concluding chapter 17 lecture here.